who was the executive director of the Ohio Commission on Minority Health. And so this was the early 80s. And so she essentially did community organizing. And so my mom was my favorite person in the world. So we would travel the highways and the byways of Ohio, and she often started her speeches this way. And I could have never imagined that here, more than 40 years later, I would be standing in one of those fine medical facilities of which she spoke, actually delivering babies in one, and that her words would ring just as true today as they did in the 1980s, despite the fact that it was her life's work to make sure that they didn't. And so I've dedicated my career to the next step. So in the 80s, she was just trying to convince people we do have a problem. We all know that we have a problem at this point. The question is, what are we going to do about it? So this is where I work at Barnes-Jewish Hospital in the middle of the city of St. Louis. And to the right, you see a heat map of our region. So the Mississippi River is running down to the east here, and the little blue dots represent all of the clinical sites that we collaborate with. Barnes-Jewish Hospital, where I work, is number 2. And this is a heat map of the preterm birth rate in our region. And so red represents bad, right? Like preterm birth rates that are up to 18%. And so if you go 1 mile north of my hospital, you see preterm birth rates that rival that of the developing world, some of the worst rates in the entire world. And if you go 1 mile to my west, you see rates that rival Western European nations. So, some of the lowest preterm birth rates in the world. And so even if you know nothing about my city of St. Louis, Missouri, I bet that with almost 100% accuracy, you can predict who lives to my north and who lives to my west. And it's so bad that patients are terrified. So, you went from my mom's day when people are like, health disparities aren't an issue. What are you talking about? To patients know it. So do you know that I have Black patients who travel hundreds of miles to see me as a high-risk obstetrician, hoping that my identity as a Black woman will see value in their lives and provide protection and take their concerns seriously. So I want to express to you that our patients are also terrified. And in that vein, we actually wrote a love letter to Black birthing people from Black birth workers that was published in the St. Louis American newspaper. It was also published in the March issue of OBG Management. And sometimes it's hard to have these conversations or to start them. And so a lot of my colleagues have come up and said, thank you for writing this letter, because we actually give it to patients now as a way to open up dialogue and conversations that are otherwise difficult to do, and creating a safe space and saying, I see you, I hear you, I'm really going to try to take good care of you. So let's go over the epidemiology quickly, and I'm going to spend exactly 1 page on this topic because I think we know it well. When you look in reproductive health across every dimension that you can think of, we tend to have disparities, right? Whether it's in infertility or preterm birth, maternal death, cervical cancer, birth control, we have an issue in our field. But the question I pose to you now is, are all health differences unfair? I'm going to give you a few hypothetical situations. So if I tell you that football players have more arm and leg fractures than people who don't play football, is that fair? Or what if wealthy people have higher rates of some illness than poor people? Do you have a problem with that? Younger adults are generally healthier than the elderly. Or men have shorter life expectancy than women. These are differences, but are they unfair? So for some definitions, this report is now more than 20 years old, but I still like it conceptually because on the y-axis, we have either quality of care or let's say, outcomes for some disease. And then we have, let's say, a white patient population and a non-white patient population. And there is a difference in the quality or in the outcomes that they receive. And so let's dissect that difference and what's happening there. And so at the top, we see clinical appropriateness and patient preferences. So let's say that we're working in the ICU and there's a patient that's like, leave me alone. I don't want the tubes. I don't want all of this stuff. Like, just let me be. And then that patient has a higher mortality rate than the patient who's like, pull out all the stops, do everything. We want to listen to patients should have autonomy and the ability to decide what they want and what they don't want. And so I would argue that, that is really not part of this disparity because we're weighing what is important to the patient. But also going into that difference is the operation of the healthcare system. What is the legal? What is the regulatory climate? Is there discrimination? Is there bias in the way that we are treating patients? And that is the part of the difference that is creating the disparity. So I promise I'm not going to read slides to you, except for the next couple, because I think that the definitions are important. This is the Healthy People 2020 definition of health disparities. a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based on their racial or ethnic group, religion, SES, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. And so the fact of the matter is that some of us face greater obstacles to health than others. Health equity means that all of us have a fair and a just opportunity to be as healthy as possible, which means that we have to take away obstacles like poverty, discrimination, and their consequences, powerlessness, lack of access to good jobs with fair pay, education, housing, safe environments, and healthcare. And so a conceptual framework to help us think about this a little bit more is, we are all functioning in a larger healthcare system, and you have the patients and you have the clinicians, and then we intersect. And every time I see this schematic framework, I think of the book, When the Spirit Catches You and You Fall Down. Have any of you read that book? When I started medical school, it was required reading. That was the book that we all read together. But you have this situation of a family who loves their child and is trying their best to advocate for their child. And you have this medical team that is trying to provide excellent care for this child, and they just keep missing each other, right? So what's happening in that clinical encounter that is contributing to differences in outcomes or disparities? And then this larger healthcare system. This is a schematic from a grant that I wrote where I tried to make the point that a lot of times when we're thinking about interventions to address disparities, we focus on the patient. So if this patient would just have better health behaviors, if they would just, access the system more and come and see us more, like it's always like what the patient needs to do to change the outcomes. And I would submit to you today that our patients are not the problem. That the problem is that, we act like they're living in a vacuum, and they're not. They're living in a community, and they're functioning in our healthcare system. And so, in the years since my mom was doing this work, and in the 15 years that I have been doing this work, we have largely failed to move the needle. And I would argue that that's because we are looking at the wrong people and asking the wrong questions. If we continue to focus exclusively on the patient without taking a broader perspective, we will continue to fail to move the needle. I really like this framework that I am taking from Dr. Joya Crear-Perry. I've adopted it. But a lot of times when we're having these conversations, we say that the issue is the social determinants of health, right? Like what it takes to, have good and safe housing and drinking water and access to food and all of those things. And the social determinants of health are where the money is. But we fail to look at the root causes. So why are the social determinants of health as they are? Because of power and wealth imbalances. You can't have these conversations. And my earlier slide about are these differences unfair? Power. You have to think about power in the way that things are distributed. And what are the root causes? Institutional racism, class oppression, gender discrimination, and exploitation. So the social determinants of health, it's true. We're focusing a lot of effort there, but what are the root causes of why the social determinants of health are as they are? And the last thing I will say in this section of the talk is that, I'm a high-risk obstetrician, and so I tend to focus on people during their pregnancy. But if we are only focusing on pregnancy and not the before and the after, then we've missed the mark. And so I use this slide a lot because this is a hypothetical. I do a lot of work in diabetes. So let's just say that the y-axis is diabetes. And when you cross that threshold, you actually get to diabetes. And so hopefully people live on the black line and, you're born, you take a little bit of a metabolic hit in pregnancy, and then you recover and you're done. Most of my patients live on the red line. So let's say that your mom had GDM. So you already took a little metabolic hit before you even got here. And then you hit your reproductive years, but you already have some comorbidities and you're at higher risk. And so you actually cross that threshold to GDM when you get pregnant, but you're young, you're healthy, you're turned back to normal. But not too many years later, you have type 2 diabetes. And so my life's work, what I've really tried to do is move things. And so that people, if they get type 2 diabetes, it's when they're 80 and not when they're 38. So my point here is that we have to look at the before and the after and not just focus on, a period of time that is less than, 5% of a person's total life. Okay, now the time for the mental break that I told you about. So if you can either take out your pencil and paper or your computer or whatever you have, and I want you to just in a column, Down on the left side, I want you to write the initials of the people in your life who are your ride or dies. They have seen you at your best. They have seen you at your worst. They still love you, and they are not a family member. So no blood relation, but your ride or die people in your life. So you can go ahead and I'm going to give you about 30 seconds to go ahead and write those down. So next, I'm going to say to you some dimensions of identity. And if the initials of the people match this identity, I want you to just go ahead and give them a check, okay? So give a check for everybody on your list who is has the same gender identity as you. The same race as you. Same religion. The same native language. A similar level of educational attainment. Okay. Is anyone willing to share what their experience was? Don't be shy. Just shout it out. Okay, so all about the same. Anybody else? Okay, I see heads nodding. Is there anybody who's didn't have that experience? Okay, tell me more. Okay, 2 are male. Okay, so 1 has a college degree, but not like graduate school, won't be on that. Okay. Okay, so 3 of the 6 fit all of the criteria. Okay, so I've done this exercise several times now, and people tend to have the similar experience to the majority of people in the room. The people who are closest to us in our lives often are mirror images of who we are, and that's actually pretty normal and natural. And that's called affinity bias, that we tend to have greater trust, greater empathy, greater cooperation with people who are similar to us. And this is a Facebook post that I put up on Mother's Day, basically says, Happy Mother's Day to the women in our lives who did not give birth to us and are connected, not connected by blood, yet treat us as their own. So these are some of the women in my life who have just adopted me and I love dearly. But what do you notice about all of them? They all look just like me. And that is affinity bias. And I want you to think about our patients and how often our patients, are they completely similar to us or are they socially dissimilar? And what does that mean for the affinity bias of trust and cooperation and empathy and having regard for them? And that brings me to implicit bias, which I think that people have spoken about a lot now. So, explicit bias are things that we just wear on our sleeves. Like it's clear, like you think about the picture of like the Ku Klux Klansman, versus implicit bias are things that are beneath the surface and that we don't even realize are there. And I would argue that bias is not inherently bad. Actually, in medicine, bias can be quite good. So if I get called because a patient is having a postpartum hemorrhage, I just run, right? I don't think like, okay, on Williams page 222, it says that the first thing I need to do, the patient will be dead by the time I went through that mental exercise. I take my, lifetime accumulated clinical experience, the things that I've learned, the things that I read, and they all are just kind of smushed in my brain and I go into action and I take care of the patient. So all of us actually need to have bias to do our jobs well. So to be clear, bias isn't bad, but we also have to realize that our biases have the potential to cause harm. And it doesn't mean that we're bad people or we woke up this morning and it was like, I think I'll be racist today. It's not that at all. We're not necessarily bad people. But if we don't recognize that we all have biases that we come with and try to check them, we all have the capacity for harm. So implicit bias is attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner, and it can impact how we judge or care for people who are socially dissimilar from us. So, like get rid of the image of the Klansman, like we all have the potential for this. And I think the first time in medicine that people started to actually embrace the notion that maybe there is something there is, and I chose this study, but there's several like it. I remember the first one was at the Durham VA in the 90s, I think by Kevin Schulman. But basically they would go to medical conferences and give a clinical vignette where there was a clear evidence-based answer for what the right answer was for the patient. And the only variable in the vignette that was different was the gender or racial identity of the patient. And so they would give these vignettes, only changing those variables and say, what are you going to do here? And what do you think they found? Consistently, the patients who identified as women or people of color got substandard care and did not consistently get the evidence-based recommendation compared to people who identified as male or white. Time and time again, this study has been replicated with the same finding. I want to make the point before we go any further that those of us who believe that we are most immune to ethical dilemmas are actually the most likely to fall victim to them. So my junior year at Stanford, I did a domestic exchange program at Spelman College in Atlanta, Georgia, which is a historically Black women's college. And I took an introduction to epidemiology course that was taught by a CDC epidemiologist, PhD level. He was a Black man, and I had the utmost respect for him. I loved him as my teacher. And he shared with us that in the 1960s, when he was a doctoral student, that he had traveled to Tuskegee and he had worked there for 4 months. And it wasn't just him. There were Black medical students from, Meharry and Howard. There were lots of students there working. And he was there for a good 3 months before he ever started to think, something here doesn't feel right. And I heard my professor say this, right? Like we look at with the lens of history and I'm like, wait, how did he not realize that something was not right? And if you look at the history of the Tuskegee experiment, it actually started off beautifully and completely ethical, right? Syphilis was killing people and they didn't understand the natural history. They didn't understand what was happening. And for Black families in Tuskegee, if you had a family member that died of syphilis, it could bankrupt you because you couldn't pay for the burial expenses. So they have this natural history study that provides burial expenses. There is a nurse from the community who is helping to administer the study and actually communicate with the patient. So if you look at how it was set up at the time, it was an amazing, beautifully well done study. But about halfway through, something happens that changes. What is it? Penicillin is discovered, and there's now a treatment. Do they give that treatment to the patients? No, they actively seek to not give the treatment. Like the nurse will go to physician visits with the patients to make sure that they don't get treated so they can continue in the study. And that is the point at which Tuskegee becomes an unethical experiment. And I've never forgotten what my professor said, lest we be the people who sit here and stand in judgment of other people, to realize that even today, sitting in this room, that could be us doing it in some way. And so to always try to evaluate within ourselves, like what are we doing that potentially can cause harm? And so now we get to go to the much more fun part of this talk, which is what are the solutions? Where do we go from here? I think we need a life course perspective. As MFMs, as OBs, we can't just focus on our little 9 months of pregnancy. We need to target the likely causes like the social determinants of health, implicit bias, and racism. PQCs have actually shown a lot of promise in this area, and then support evidence-based interventions. And group care is the one that I have spent a lot of my career focusing on. Do you guys practice group care here? Are people familiar with group prenatal care or centering pregnancy at all? Okay, I see some nods. And for those who aren't as familiar with it, this is a picture of our group care program at Barnes Jewish Hospital. So I'm just going to paint a picture for you. So you or a loved one is pregnant, you come into our clinic. Normally you sit in the waiting room, but no, if you're in group, you come check in, go right to the group space. It's a nice, big, pretty conference room. And it's set up in a really friendly manner with snacks in the front and, a nice little circle. And so you come in, you get your snacks, you check your own blood pressure, you check your own weight. So if you ask a patient in group who's coming into triage with an elevated pressure, hey, well, what have your pressures been running? They know, because they are checking their own numbers and keeping track of them. So there's a little 30-minute period at the beginning where each patient gets assessed by the obstetric clinician. It can be an OB, a midwife, a nurse practitioner, a family practice doc. And it's just 3 minutes where you check the baby's heart rate, look at blood pressure, say, is there anything concerning you about your pregnancy? And a patient might say, oh, doc, I have this pulling feeling in my groin that's really annoying. And I can say, you know what? I bet somebody else in the group probably has that same complaint. Do you mind if we talk about it in the group? And they usually say yes. So the nice thing as a clinician is I'm not saying the same thing 15 times a day. because you just refer it over to the group space. And when we get in group, the patient on her 5th kid is like, girl, that is that round ligament pain. Let me tell you about it. And they go to town. And so as a clinician, if I'm doing my job well, I have very little to say in a group. The wisdom, the power, and the knowledge are coming from the patients in the group if you're doing it well. It's a facilitative style with fun adult learning principles applied. And the first time I saw a group, I was a first-year fellow at WashU, and my oldest child was 4 months old. And the topic that day was infant care. So does anybody ever have time to teach about infant care and regular prenatal care? And so they were talking about, feeding and the fact that like crying is a late sign of hunger. Like the baby gives you tons of signs before it starts crying. And so they're kind of saying the baby goes, oh. And I was like, I'm a physician at this point, right? I wish somebody had told me this 4 months ago, because I figured it out for my kid, but it took me a second. So there's just time for a lot more things than you would ever have time for in the traditional 10-minute wham bam, thank you ma'am visit. So group care is a lot of fun, but that's not actually why I got involved in it. It was this study in 2007 from Jeanette Ikovics. It was a randomized trial between Emory and Yale of patients who were randomized to either get group or individual care. And what they found was really interesting, a significant risk reduction in preterm birth rates for patients who were randomized to group. And so you see that for all comers, there's a 33% risk reduction. Remember, this is still the age of MEAS, where this is similar to what we're thinking at the time is the reduction that you get with 17 OHP for preterm birth. And this is just a simple intervention that you do in your clinic. But when they did the subgroup analysis of just Black patients, there was a 41% risk reduction in preterm birth. The disparity went away. And that's what caught my attention. Like up to this point, this was like the first intervention I saw that actually seemed promising to do something. And so when I was a fellow, we published a meta-analysis. I'm a nerd and biased. Like metas are like my favorite study design. They're kind of fun to do, but also they're free. So if you want to do research and you have no money, but you have time and energy, you too can do a meta. And so we did a meta-analysis, basically looking at all of the literature and separated out the observational studies versus the randomized studies. And let's see. Yeah, it is working. Okay, so here's the observational studies and the randomized studies. And if you don't know how to read a forest plot, and I'm not going to take my time to do it today, but you should learn this because this can definitely be on, they definitely can cover it on MFM boards. But when you looked at the observational studies, this is showing you that it crosses the line of no effect. And for the randomized trials, the same, and overall, no difference in preterm birth. And up to this point, group care is being hailed as this wonderful, amazing thing. No difference. But we did a subgroup analysis of just the Black patients in the high quality trials. And what did we see? That 45% risk reduction in preterm birth rates for Black patients who were randomized to group. And so overall, the finding of our meta-analysis was that there was no difference, but we got hate mail, kind of like, how could you disparage this amazing form of care? And I always like to show this. These are the words of, Janine will appreciate, Dr. Tooley, who was my mentor during fellowship. And these are his words. We reported our findings dispassionately in favor of our role as scientists rather than our enthusiasm as practitioners. Like, can you say that any better? My working hypothesis of group care is that it's fun. Everybody loves it. But it actually improves outcomes for those among us who have the worst ones. If you are the patient living a mile to my west in St. Louis and you were going to do really well anyway, is group care going to help you? Probably not. You'll like it. If you're living a mile to my north where your health outcomes are terrible, is group care going to move the needle for you? Probably. And we just did another meta that I just submitted to the Green Journal for diabetes group care that shows very similar findings. So patients with diabetes who are in groups, much better outcomes. So I think it's, you can apply it to everybody, but you're going to get the most bang for your buck and people who are at high risk for bad outcomes. But why does it work? What's actually happening here? This is a study by Novix that is looking at what's more important for group care. Is it process or content? So if you have a group care curriculum, is it important that you check every box and you make sure that, okay, today we're talking about labor pains and the patients come in talking about contraception. And you're like, today's not contraception today, today's Labor Day. No. Oh, wait, let me tell you what the study says and then I'm going to editorialize about it. Okay. So the study says that essentially process is more important than content every single day. that you go where the patients want to go. And I see that that's what's borne out. If the patients come in talking about breastfeeding, that's where we're going to go with that day. So you're responsive to the patient needs. This is a qualitative study that was looking at shared medical appointments. These are for patients who are not pregnant. That's what group care is called, kind of outside of pregnancy generally. And they highlight these, mechanisms of action. And I've taken the liberty here of highlighting them in either yellow, if it reflects kind of something that's acting on us as clinicians, or aqua, if it's acting on the patient. And so what you see here is that for the patient, it combats isolation, vicarious learning, feeling inspired by your successful peers. In my diabetes groups, I'll have a patient with GDM, and I'm like, you need to start insulin today. I'm not taking that. I don't like needles. I'm not doing it, like ready to tell me off about insulin. And then the patient who's had type 2 diabetes for 5 years is like, it's really not that big of a deal. I just do this. And like, this is what I do to make it so it doesn't hurt as much. And they take the insulin. So there's also something about that peer learning, that what their peers are saying is infinitely more important than what I have to say as a physician. First-hand health knowledge, and then increased trust in the physician. If you see your physician or your midwife taking good care of your friend in group, then you start to think, well, they're probably going to have that care and concern for me. But the longer that we've been doing group work, so it's approaching a decade now for the program at WashU has been there for 20 years. I've been involved in it for 10. I started to realize that what first brought me to group care, once again, focused on the patient, thinking, oh, it's great education and support. We're doing all this stuff for the patient. It's actually functioning on us. I think that group care inadvertently is working on clinicians and healthcare systems, because the same patient who always shows up to my individual care clinic at 4:45, my last patient of the day, is late, then makes me late to pick up my kids. And I'm like, here we go again. And I'm annoyed, right? As soon as I see the name on my schedule, I'm annoyed. Well, put that patient in group. And then I realized that she took 3 buses and walked 20 minutes to get to me, that she has housing and food insecurity, that her partner is unkind to her. And then all of a sudden, those same things that were completely annoying me, I actually have empathy and concern for her, because I could have never known that in my traditional 15-minute visits. And so I think that group care is also acting on clinicians. So, friendships that are forming, improved collegiality, learning, actually having adequate time. So when you have those 10 patients in your group for the half day, you're not worried about like the 6 people who are in your waiting room late as you're running behind and stressed out about it. Like, they have your undivided attention. And so I think that it's actually kind of restoring medicine to the way it was meant to be practiced in relationship. I don't like going in at 2 a.m. to do deliveries, but I'll do it for my group patients because I'm in relationship with them. We published this paper in AJOG, I think around 2 years ago now, that makes this point that, the reason that group care is working and what we need to start thinking about in other interventions are what are things that, service the patient, but also apply to us, the clinicians and the healthcare systems in which we work. Which brings me to Elevate, which stands for Elevating Voices, Addressing Depression, Toxic Stress, and Equity. And it's a community-engaged group care intervention that we've been doing in St. Louis for going on the last 8 years. But first, this quote: programs are short-term interventions that create temporary improvements in the wake of challenges. Policies, on the other hand, are covenants we collectively choose to live by, as articulated in legislation and regulation. They inform our socially accepted mores and ethics. This quote is from Reverend Starsky Wilson, who chaired the Ferguson Commission. Michael Brown was murdered about 8 miles north of where I currently practice. And Reverend Wilson chaired the Ferguson Commission that was designed really to address what did we need to do within our community in the wake of that act. And now he leads the Deaconess Foundation. But I think he makes an excellent point that I want to leave with all of you. This is not where I'm going to focus most of the rest of my comments, but I think as physicians, as clinicians, we create these interventions that are wonderful. But if it's just an intervention, it's probably going to die with us. We actually need to be thinking about what are the policy implications, like what are the things that we can do to make sure that there is sustainability long after we're gone. And so this was one of the things that as we started to do the work of Elevate, we were thinking about early on. And I'm getting ahead of myself a little bit in the story, but we have been advocating with Missouri Medicaid since the beginning. Right? It's been 8 years. And I'll tell you at the end, I think we finally made the breakthrough so that long after I'm gone, I think the work will endure because the payers are now involved. That's how you actually make change. So in the summer of 2016, one of my colleagues, who both Erin and Janine know well, Melissa Tapey, is an OB on our floor. She's also the chief medical officer at the largest community health center in St. Louis called Affinity Healthcare. And she convened all of the group care providers in the city of St. Louis to come to her largest health center in the basement and talk about what was within our power to address the abhorrent preterm birth outcomes and infant mortality rates in our community, right? Preterm birth, 18%, completely inexcusable. And so when Melissa convened us in the basement that morning, there were some things that we really quickly agreed on, that we needed to do transdisciplinary cross-institutional work. So the people in that room were competitors. Like, we historically have competed for patients, not played nicely in the sandbox, and then we had to get over that stuff. That we needed to address the reproductive health inequities in our community, and that patients needed to be part of the work. And literally the only meeting we've ever had that did not include the patient was that first one. Patients have been integral to the work ever since. We disagreed on a few things. One was, what is the role of research? I'm a researcher at heart, so I clearly thought that that was really important, but the fact of the matter is that researchers had historically come into communities and extracted the value that they needed. As soon as the money was gone, so were the researchers, and then did whatever they did with the information, never giving it back for any benefit within the community. So the consensus on that early day was, we are not doing research. Like, researchers have done us wrong. And so in those early days, we did program evaluation, because I did successfully argue that if we figure out something great to do together and we are not systematic about it so we can tell the story, then it will go away when we do. The next question is, how do we address these root causes and policies that are impacting reproductive health inequity? And then what does accountability look like? If you're going to bring patients to the table, how are we going to be accountable to what they say? One of my colleagues, we were speaking at the Illinois PQC last week, and she made the point that if you're going to bring community members to the table and ask their opinion, your answer should typically be yes. Don't bring them and then discount what they have to say. Like, our answer should usually be, we hear you, and yes, we are going to try our best. And so we used the Ferguson Commission's report. This is now 2 years after Michael Brown's death, to really guide our efforts. So preparing the work, so building an inclusive team. So there were obstetric clinicians and mental health providers and lots of people at the table. Because the other thing in that first meeting we realized is the mental health burden in our patient population was like overwhelming. And if you had a mental health issue in St. Louis, and you were poor, God help you with actually finding anyone who's going to, it was almost like, why do we even screen for an EPDS? Because when they're positive, there's like nobody to actually take care of anyone. And we realized that 80% of our patients had a past or present mental health diagnosis with no real care. And we felt like that was actually adversely impacting everything. And so mental health, we realized early on, we need to address that. So we had mental health clinicians, some of the leaders, thought leaders in our city, nonprofit organizations. What are our core values? What are our processes and principles? And what are our expectations of each other? We engaged with community. So every single site brought community representatives to be at the table. We had to think systemically and acknowledge race. The elephant in the room in those early days is that almost all of the clinicians were white. Almost all of the patients were Black. What are the implications of that? Like, how do we deal with our own stuff before we go to patients? And then how are we going to tell the story of the work and make sure that it's accessible, and that we are not just taking, but we are communicating back to the communities that we're working in what we found. And this involved trusting, acting, and asking. So when you ask community members for their voice, not trying to filter it through our own, lens, or like, oh, but we've never done it that way, but just being open, and really trying to be receptive. Everything that we did, we tried to use a racial equity lens and ask this question. Once again, this is from the Ferguson Commission report. So if you have a policy or a procedure, who benefits from this recommendation? How are different racial and ethnic groups going to be affected by it? And then what, or even more importantly, who is missing from this discussion so that racial and ethnic disparities can be eliminated? And this is going back to our maternal mental health inequity. So, there was kind of this leaky pipeline where, we were screening, but then there was nothing to do with it. So people were falling through the cracks all along these lines. And how could we, within our power, address it? And one of the things I want to step back and say is sometimes these problems feel so big and so insurmountable. It almost feels like I don't even know where to start. Like, you're paralyzed because it's just like, there's nothing I can do. And our approach is, what is within our power and our ability to do as a group of, group prenatal care clinicians working in the city of St. Louis. And so we formed teams. We formed a curriculum team and decided that the curriculum that we were all using was essentially built for affluent white women that did not reflect our patient population. And so we created and designed a curriculum by Black patients for Black patients. And I would pause for a second here, because when we write manuscripts or grants, they often criticize us and say, well, if it was designed for Black patients, then why is everybody in Elevate? And our hypothesis is that if you create an intervention that improves outcomes for those among us with the worst outcomes, you actually elevate and improve outcomes for everybody. So the curriculum we designed is for everybody. We have Spanish-speaking groups, we have English groups. It's been adapted at various sites. It's actually for everyone, but was there ever a curriculum designed for and by Black patients before this point? So the curriculum team focused on going through and making sure that it was culturally sensitive, that it was anti-racist, that it was trauma-informed, and created a curriculum over the course of a year that essentially married a behavioral health intervention that was evidence-based with cognitive behavioral therapy, mindfulness, into prenatal care. So no stigma. You come, it's one-stop shopping. You get your mental health needs addressed and you get your prenatal needs addressed. And I remember when we were designing the curriculum, we were asking the question, should we ask patients about the trauma they've experienced? Because about 70% of our patients have a history of trauma. And the OBs and the mental health clinicians in the room were kind of erring towards no. If we ask patients about trauma, will we re-traumatize them by doing that? And one of the patients in the room, Rochelle, who still works with us to this day, stopped us and kind of checked us. And she was like, that's the problem. You all don't ask us about our trauma. And just because you don't ask us doesn't mean it didn't happen. And then you sweep it under the rug and it never gets it. You have to ask us about trauma. It kind of took the air out of the room. And it was like, wow. So if you unmask trauma, then you are ethically obligated to then give people the support to work through it. And so then we had to figure out, right, it completely changed the course of the conversation, the discussion, and we designed a robust referral network. So the things that we couldn't handle in the group space, there was a referral network so that people could still get the care that they needed. There was an evaluation team that I led, and the evaluation team was like the early part of the research in terms of how are we going to systematically tell the story. And then there's a steering committee that is still in existence that meets quarterly and provides the overall guidance and direction for what we're going to do. Because, I'm telling you the intervention part of the story, but there's also a policy part of the story that's going hand in hand with this. In order to prepare clinicians to do this work, we needed some training. And so this is meant to represent an iceberg, and the tip of the iceberg is what we were doing in terms of cultural competency training at all of our respective institutions. Often it's, do you guys have this where you have to do all of these trainings and learning things online and like the module, and it takes 3 hours. And if you're like me, I try to game the system. Like, how can I figure out how to click through this stuff as quickly as possible, check the box and keep it moving? So, all the places had their own little baseline stuff that they did around implicit bias. At the next level, we did trauma-informed care training. So at all of our sites, everybody who was patient facing, we still do this today. So phlebotomists, sonographers, front desk staff, clinicians, like everybody who has any interaction with patients gets a 2-hour trauma-informed care training. And I've done a lot of trauma-informed care training at this point, but the most impactful was my first. And I remember the facilitator saying that when a patient comes in and the patient is cussing and fussing and throwing stuff, and you just want to be like, what's wrong with you? Stop and take a deep breath and think in your head, what happened to you? Because just like when we woke up this morning, we didn't get up intending to be racist. The patient didn't get up out of bed intending to like throw stuff and act, be disorderly in the clinic, to say it nicely. Something probably happened to that patient where their power was taken away. And that is why they're acting out in that moment. And you actually don't have to know what that was. But if by just thinking what happened to you, it changes the way that you show up for the patient in that moment and don't take it personally. I think about the example of a patient that I saw last week where we had scheduled her incorrectly. And so she came in for an ultrasound, was really looking forward to seeing the baby, took off work, mom took off work, husband took off work, comes in, and we had not scheduled her correctly. And so she was too soon for her next growth. So they canceled it. And she was mad. It took me 2 seconds to get my little handheld ultrasound, go in and show them the baby and the heartbeat and the head. Everybody's happy and we're done, but just as easily we could be like, oh, sorry, we messed up the scheduling. We'll see you next time. And the patient is mad. And we're like, why are they acting like that? So making sure that we are patient-centered and recognizing what our patients are going through. The next part of it is just for the Elevate facilitators. So every group is facilitated by an OB, midwife, nurse practitioner, family practice doc, some OB clinician, and a co-facilitator that's different at the different sites. So medical assistant, health educator. All of the facilitators go through an 8-hour Crossroads anti-racism training. I don't know, has anybody in the room done Crossroads training before? It's actually wonderful. One of my other hats is I'm chief of our division of clinical research, and we just did the training with our entire division. It's wonderful, and it helps you to kind of, I think we often don't have the time and space to process through these things. I don't like doing tons of trainings, but this one is actually invaluable. So all of our facilitators go through the anti-racism training. We do 16 hours of group care facilitation and behavioral health training. And we used to separate them, a day of group care facilitation, a day of behavioral health. And we realized in February of this year, we're messing up. They actually go hand in hand. Like, I think that when OBs hear like, you're going to get behavioral health training today, they want to run. But if the way that we have largely done it, so we're putting cognitive behavioral therapy and mindfulness into the group care sessions. And the way that we have done this is through the activities. So if you just do the activities that we have put in the sessions, you are actually getting all of those evidence-based techniques through. And then after doing all of that training, which totals about 3 days, you actually do the intervention. And I would argue that just by coming to work and doing the intervention, you're still getting trained, but now your teachers are the patients who are showing you day to day the social determinants of health at play in their lives. And I would argue probably changing the way that we show up. And that impacts systems and policies. Like, that's how all of us came together as group care clinicians in the first place. And this is to remind me, this is a picture of Rochelle, the patient and partner I just told you about, doing a trauma-informed care training for our resident clinic staff in March. So how cool is this? Our patients turned partners kept getting invited to come share their story. And at some point they were like, we're sick of going and sharing our trauma with medical teams. Like, it feels like they're just like, oh, that's so sad. That's so hard. And then they go on about their business. So they basically said they don't want to do it anymore. They did a train the trainer session for trauma-informed care. So now all of our trauma-informed care trainings are delivered by patients. Now a position of power, teaching the very medical teams that care for them about trauma-informed care and embedding their life experiences and expertise into those talks. So for our implementation, we wanted to see, proof of concept, like, can we do this? Does this curriculum work? We weren't trying to see outcomes. We just wanted to see, can we do this? So we piloted it in 3 sites: Affinity Healthcare, the largest community health center in St. Louis, Barnes Jewish Hospital, where I work, and St. Mary's Hospital, which is the teaching hospital for OB for St. Louis University School of Medicine. And patients either got traditional care, our Elevate group care curriculum, or standard group prenatal care or centering pregnancy. And then we did look at their neonatal outcomes, even though we weren't powered to really see this. All right, so this is what we found. There was a 50% decrease in postpartum depression for patients who participated in group care. There was a lower C-section rate. There was a higher rate of breastfeeding when patients went home from the hospital. And our preterm birth rate in our individual care group, 18% is what we see in our patient population. Not a single patient in Elevate had a preterm birth. And while it was not a randomized trial, I can tell you all kinds of methodologic issues with it. It suggested that maybe there's a there. And these are our qualitative outcomes that we did in interviews, which I'll give the slide deck so you guys can read these as well. And so here's a little bit of testimony time. Testimony time is a tradition in the Black church where you get up and you share something that has happened to you, that maybe you were able to get through a trial and you were able to prevail. And so in 2016, when I was going to these community meetings in the early days, when there was no name for Elevate, it was just a bunch of people meeting, trying to change things in our community. My mentors, very well-meaning, said to me, Ebony, you're on the tenure track. You're spending too much time in the community at all of these meetings. Like, the currency of academia are papers and grants. And that's where you need to be focusing your time. Like, this is not a good use of your time. And there was truth and wisdom to what they were saying. But in my heart, it felt like being involved in these community meetings and what ended up becoming Elevate, but I didn't know it at the time, was valuable. And remember, at the time, they were like, we don't believe in research. So I couldn't even do research. It was just a grassroots movement at that point. So imagine my shock when my first R01 became scaling Elevate across the entire state of Missouri. And to be clear, There was no research that happened for the first 3 to 4 years we worked together. It was just relationship and trust building. But with that relationship and trust, we ultimately did decide research had to be core to what we did. And so imagine that this community work became my first NIH R01 funded trial. So, listen to your mentors sometimes, but not all the time. So now Elevate is at 8 sites across the state of Missouri, spanning from St. Louis across Interstate 70 to our colleagues at the University of Missouri, Kansas City, and Truman Health, which is their safety net provider for Kansas City. And our sites deliver 80% of the Black patients in the state of Missouri. So now we're randomizing them to traditional care or Elevate 2 to 1. So the vast majority of patients get randomized to Elevate. And we're following them to see our primary outcome is perinatal depression, and then also looking at preterm birth, small for gestational age. And it's a hybrid implementation effectiveness trial. So, when you're doing community-based research, you can't be rigid and say like, okay, everybody has to do this. All of our sites are doing this a little bit differently. So for example, at Barnes, where I work, we're doing it in our teen clinic. The teen clinic is 20 years old. The clinicians there feel very strongly teens should be getting their care in groups. Group care is better for teens. Okay, maybe, not totally, not sure. But the way that we do it there is every teen that comes in that's pregnant goes into group. And then our research assistants approach them and say, hey, we have this program called Elevate. There's a 1 in 3 chance that you'll get randomized to regular care with the same clinician. Is that okay with you? And that's how we do it there. Most of our other sites is the opposite. So we say, hey, are you interested in group care? Yes, no. And then they get randomized at that point. So there's these little nuances that are different between sites. Some sites have a couple of clinicians who are champions. They believe in Elevate and they're like, we're going to do it. And they are, leading the charge. And they're like 2 of 30 clinicians doing it at their site. Affinity, that started this whole thing. Dr. Tapey is the chief medical officer. She voluntold everybody that they will be doing Elevate. They all got trained, the OBs, the midwives, everybody there does it. Does it matter how you do the intervention if you were a volunteer versus a voluntold? I don't know. So we're looking at those things as well. And it's funny because we do site visits to all of our sites every year. And when we finish kind of giving our little presentation, I go around to the clinicians and I give them their stack of surveys for the year because we're going to do equity equal for all. So the clinicians are research subjects just like the patients are, because we're trying to see how is this intervention impacting us as the clinician. And so I want to share with you, I'm going to need help now probably, a brief video in the patient's own words of this intervention. And it's just a little 30-second video.
What's different about Elevate? It offers an approach to overall holistic health for Black and brown birthing people.
Elevate was created by and for Black women. You get all of your prenatal care in a group setting. You also get mental health needs addressed.
We want the environment to be super welcoming.
It has opened me up in so many different ways.
And tune me more into myself and the baby as well as other mothers.
Being a part of this initiative has helped me and my family to grow stronger.
Join. We need you to come join. It gives you hope that things can get better.
Thanks. And I want to leave you with one more quote. My mother died during the pandemic, and before she died, I never acknowledged her work. I think I wanted to stand on my own 2 feet. And since her passing, I open almost every talk with her words, and I close every talk with her words. And her mentee reminded me at her funeral of the fact that she would often close her speeches with this quote, and I leave these words with you today. Go in search of your people, live with them, learn from them, love them. Start with what they know, build on what they have. But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. I want to thank our funders. And I also want to be very honest and say that I tell this Elevate story like it was seamless. No, there were 3 times that we were within 2 weeks of not being able to pay our bills, not being able to pay our program coordinator. So, and everybody was there, whether the money was there or not. So I told you the nice version of the story. There were many peaks and valleys along the way. I want to thank my research team that you see pictured here, and most importantly, the patients turned partners in Elevate. And with that, I'd be happy to take questions.
Good morning, Dr. Carr. Thank you so much for this presentation. We started the Centering Pregnancy, the group pregnancy model, building on that enthusiasm from those initial reports, and have since kind of narrowed to more specific populations. We've also had some trouble with the pandemic. So how did Elevate survive, thrive, or become hampered during the pandemic? And what do you see for the future for things like these group prenatal care programs from a policy standpoint?
Sure. So the pandemic hit us pretty hard too. So all of our group care programs shut down. We tried to go to virtual platforms during that time with varying levels of success. What we found is groups that were already kind of to session 2 or 3 by the time they would, because it wasn't just the first time. And then you had like the Delta wave and the Omicron wave, because we had tried to restart. Groups that had already started converted to an online platform okay, because they were bonded. It became impossible to start new groups with an online platform, because who wants to go sit on Zoom with some complete strangers for it? We were never able to completely replicate the model online. There's some X factor that happens in person with like the friendship and the bonding that you have. The other thing I will say for group care programs is there's a paper in my head that's not on paper yet, but it's the recipe for a successful group program. I think there's probably about 5 things that you have to have for the program to go well. One of the most important is a clinician champion, like somebody who is all in, all for it. Like they don't get discouraged when only 2 people show up for a group, that they are in it because they realize that it is a really special form of care. You also need an administrative champion, somebody who makes sure that you have the space and the space is dedicated and somebody else isn't using the space when you're supposed to be there for group, or that the nurse who's supposed to be there for group doesn't get pulled to another clinic because they're short. And so a lot of times group is like the place that people get poached. And so you need somebody administratively who's helping with that. You need a certain, and I'm telling you this based on, we have 8 sites and some are thriving and some are struggling. And I'm looking at what are the differences between the two. You need a dedicated coordinator who's actually keeping things that are going, which is more expensive. You need a certain volume of patients. So Affinity, I'll use them as an example. They have 4 sites. And when we had groups running at all 4 sites, sometimes the patient population wasn't big enough. And so you'd only have 2 or 3 people. That group would get canceled, waiting for more people. And so you were on this going back and forth. And then we decided to combine the sites. So there were 2 northern sites, 2 southern sites. And so we just had one group for those. And suddenly their groups were like well-populated, big and thriving. So I don't know what the number is, but there's some threshold above which you need more patients than that. I can keep going with my observations, but I think that, if I was writing this recipe paper, if you have all of them, golden, go for it. If you have 4 or 5, you can probably make it work. If you have 2 or 5, just save your time, because it's going to be a frustrating struggle. Group care is wonderful when it works, but it takes more time and energy than regular individual care. And so one of the things that we have been advocating for, they've already done this successfully in South Carolina, is differential reimbursement. So we are getting close to advocating in Missouri for Missouri Medicaid to pay more when patients get group, because who's benefiting from group care if we really are averting preterm births? It's not the health system. The health system loses money if they don't have those babies in the NICU. It's the payer. And so the payer should be the one who is burdening the cost of, the additional cost of being able to do this well. So we've been advocating for that for 8 years. And I think we are, knock on wood, just about there. Yes.
I was just curious, and I apologize if I missed this, but do doulas have any role in the Elevate program, and what is their role if they do?
Yeah, thank you for the question. So Elevate does not have doula participation at this point, even though we would love to. One of the things that we've talked about with Elevate is it's purely an outpatient intervention. So this is their prenatal care, but then for the most part, they go to a labor floor that has none of this, right? Has done none of this training or anything else. And so as we think about our next step, one of them is, integration of doula care into Elevate. Another one is how do we incorporate this on a labor floor? And postpartum, we have a group in Kansas City that's hilarious. They kind of had like a wide gestational age spread. So about half of the group is postpartum. They're still coming. They come back to group with their babies now because they're like, we don't know what to do without this group. Can we keep meeting? And until about a month ago, Missouri had no postpartum coverage beyond 45 to 60 days. That just went through the state legislature. Wonderful news, but there's nothing to pay for it once people fall off that cliff 45 to 60 days later. So thank you for bringing up next steps that we are looking to embrace. Yes.
Thank you so much for this talk. Reflecting about on what you said about affinity bias and then your recipes for a successful group care model, have you noticed in your metas and your own observations what demographics within the group are important, particularly with race, ethnicity of the participants? Like, what does the group look like that will deliver kind of the best experience for them, and also like the lower rates of preterm birth, like the outcomes that we care about?
Yeah. So I'm going to come at this from like the facilitator lens and not the outcome lens. I think the beautiful thing is it doesn't matter. So what I have learned is to trust group process. So I remember the very first group I had, I was going to try to do a diabetes group. There was no curriculum. I didn't know what I was doing, but I was like, this was 2014. I was a fellow. And I was like, I found 6 patients with GDM and type 2 and was like, I think outcomes might be better with this form of care. I don't know. Do you want to do it with me? And so they just met with me throughout their pregnancy every other week for 2 hours. And they give me feedback at the end on what they liked, what they didn't like, and whatever. And there was a patient in that group who had a problem list that had 25 problems on it. And I was you might remember Miss Nellie, who was our diabetes nurse for forever, but Miss Nellie was like, she really needs group. And I'm like, nah, she got too many problems. I can't deal with it in group. And she was like, she really needs group. And this patient was like depressed, barely had anything to say. I had not bonded with her in our regular diabetes clinic. And with Miss Nellie's insistence, she came in group and came out of her shell, became the biggest proponent of group, like, and she had been so depressed, was new to the area, had no support system, was in an abusive relationship. Like all of these things came out when she was in group, and she was the best group member. I've had patients who were a little bit, slower and kind of perseverate in talking. And I thought they would be disruptive to group. And I'm like, I don't know about it. And they come into group and I'm just kind of like, would you stop talking? Like this is taking too long. And I'm trying to move them along. And the group members, loving, kind, patient, so like more supportive of this patient than I am being in my type A, like, let's get things moving. And the same thing with racial and ethnic diversity. So we've had patients who actually economically were very well off, and a group of patients that actually had financial difficulty. And you see that the group process still works just fine. And so what I have learned, I used to be really nervous before I did groups. Like, what if something comes up and I don't know what to say, or I don't know what to do? Trust the group. So it's okay to have like 30 seconds of silence sometimes. And the group, I don't think I've ever had a group where I was like, oh, like that was a mistake. Even people with some comorbidities, like they might still have to see MFM in addition to group. But it's actually, or fetal care patients who have something else that's going on, who don't get to really focus on like the just being pregnant part of things. They go to fetal care, but they still come to group. And so my philosophy over time has gone from being scared and trying to be very selective and micromanage the group dynamics to now I just trust the process. The last thing I will say on that topic is Amy Crockett, who's at Greenville Health in South Carolina. I've really admired a lot of the work that she's done. We have followed her advocacy book in terms of like differential Medicaid reimbursement, and her group's all comers. The easiest way to have a program is just to have like one program and everybody comes to it, and that keeps your group sizes big enough to be cost effective, sustainable. And at Barnes, we have an opiate use disorder group and a diabetes group and a diabetes prevention and a teen. You see the pattern, right? And for research purposes, that's great. For just the practical implications of having a program, I think for like just clinical care, I think the way that Amy is doing it is probably right. Thank you guys so much.